Testing 1.
Testing 2.
Testing 3.
Testing 4.
There we go. It worked.
It did.
We briefed them well.
Welcome to the Testing Podcast.
Yeah, welcome everybody.
Thank you.
And welcome to two fantastic guests, Mr. Jas Kalsi and Miss Fatima Husain. I don't know if Miss or Mrs. actually. I was like, not that it matters.
Should we say doctor?
We can say doctor. Yeah.
Because outside the UK, they'll think I'm just an unmarried woman.
Let's go with that.
Let's go again. Well, welcome, Mr. Jas Kalsi and Dr. Fatima Husain.
Thank
Does
you.
that work? Is that good?
Yeah, it's good.
Thank you very much for inviting us.
Oh, thank you for coming down. It's taken us a little while to get this organised. And I mean, there's a lot of moving parts, and you guys are very busy in your clinics. So thank you so much for taking the time out and coming to chat to us. But consultant urologist and consultant gynaecologist. I'm really looking forward to this conversation because you guys are in some ways doing something quite unique in the industry, aren't you, in terms of what you're doing together. But before we get into that, maybe just a little bit of background as to who you are and what you do and where you work.
Let's kick off for you. Yeah, Fatima, let's go.
Well, I'm a consultant obstetrician and gynaecologist, and I'm the lead for fertility services at my hospital in Wexham Park, which is part of Frimley Health in the NHS. And I've been a consultant there since 2006. I trained in fertility and IVF at Guy's Hospital as part of my research. And my main passion really is to try and progress the care of couples suffering from fertility. And I've been running clinics for all the time that I've been there, and things have changed over the years, and so things keep developing in the field of fertility, but some basics remain unchanged, and I try to focus on the clinical aspects of the patient's journey. And the beauty of my job, actually, working in a hospital where I can do obstetrics as well, I see women who are having fertility issues. They may have some other gynae issues. I can operate on them. I can help them on their journey with medication, and then see them in my antenatal clinic and on the labour ward. So,
wow.
So you get
I
that whole
really
journey.
love that part of it, that continuity. So as a consultant, we've got that role, and I love working with my colleagues such as Mr. Kalsi, urology consultant.
Wow, that's amazing. That's really cool to be able to do the whole journey. I say see them from beginning to end.
Absolutely. And some of those women have, it takes a while to get on to the moment when they actually get pregnant because they have issues. They maybe have weight issues. They may have polycystic ovary syndrome. They may have endometriosis, fibroids. And as a gynecologist, which is a bit broader than just a fertility specialist, I can help them with those things. And because I see everything from the angle of the fertility consultant, I can progress that, work with my colleagues, and progress their journey.
So I guess you might see
really special.
women, that are coming in because they've got PCOS or endometriosis, but they're not thinking about a family yet. But you,
absolutely.
like you say, you look at that through
Yeah.
the lens of fertility as well for them. So you kind of, because some women haven't thought that far yet. They're just like, I just need to deal with my painful periods.
Absolutely.
And you're like, well, actually, let's think further down the road.
Yeah, I
So-
think something called preconception planning. It's something I'm very passionate about. It's very underdone. NHS doesn't really fund anything for preconception planning. So as a fertility specialist, it's actually very nice to be able to correct stuff and get people in the prime position to carry a pregnancy.
Yeah, which is what we're all about. Obviously, not the men carrying the pregnancy, but about that preconception
Struggle
care.
with that.
Yeah.
I really love that though, because it's so rare actually to hear someone in this field of fertility where you effectively can take them right from the very beginning right to baby arriving.
Absolutely.
So often we hear with the couples that have gone through successful rounds of IVF is that once you've had that positive pregnancy test, that's kind of the job done, and off they go to the next person, whereas you actually can hold the hand all the way through. I think that's really
Absolutely.
special, and what an honour to have that. It's such a beautiful thing.
Absolutely. I think it is an honour and a privilege to look after these couples. And the funny thing is, Jas and I have known each other for a while. When I first started as a consultant, it was Heatherwood Hospital, and I used to do my ward rounds, and the man had not been tested. In fact, the men never used to even come to the clinic when I started
Wow.
as a consultant in 2006. Things have changed. And so essentially since that time, I thought, oh God, what's going on? This is a 2-person problem. So I had a very rigid protocol of ensuring the man must come to at least the first appointment. And then, of course, we discovered things and they came, and it's the right thing to do. We have to treat them as a couple. And so that is a very well established system for seeing them as a couple.
Yeah.
Yeah.
So important. Yeah, we bang that drum a hell of a lot, mostly speaking on the fact that a lot of men get kind of ignored or feel like that's the way. So it's great to know that there's something being done in your field. I guess that brings us quite nicely onto you, Jas, because you're the kind of second half of this equation of what we're talking about today. So who are you, and introduce yourself?
Sure. I'm a consultant urologist at Frimley Health, appointed in 2010, so I've been a consultant for 15 years. Passionate about all things urology, but mainly men's health and male fertility, because what we really realised, and why we're all really here, is that the man doesn't really get a look in until quite late in this whole process. So what tends to happen in this process is a couple try. If they're not successful, the man has a semen analysis. And we all know that it really depends on who looks at that semen analysis. Often these men are told it's all okay, and it's not. And IVF's been a great breakthrough in our field, but it's also been a bit of a barrier, because what tends to happen is if the man has any sperm whatsoever, they kind of get ignored. And then the female partner gets investigated and investigated and investigated, and then they have IVF. Now, what we really, Fatima and I discovered, is that there has to be a joint approach. The couple has to be seen together, and we optimize both partners. So we're passionate about not just helping patients get through IVF, but actually trying to get them to conceive naturally or without IVF. And if they need IVF, it's about making sure you get it right first time.
Yeah, absolutely.
Because this is an expensive process for both partners, financially, emotionally, physically. And so, everything that we can do to optimize that is really important. So as well as fertility, the other things, I'm really passionate about are things like men's health awareness generally. Prostate cancer, testicular cancer is a big problem in the younger patients who are having fertility issues. And we discussed this earlier, Ian. Every year I find 5 or 10 men with early testicular cancer when we're investigating them. And if they're not investigated, they'll be diagnosed much later.
Yeah.
So this is really important as a men's health awareness campaign generally.
Yeah, that's something we talk about a lot, is that relationship between male infertility or subfertility and general health.
Yeah.
We know the research and data's there that male infertility is a proxy for general health. And I think Cheryl Homer said it on the podcast when she came in here. It's like we owe it to men to be actually investigating them properly around all aspects of their health and their general health and their fertility health all together. But it's just not happening, is it? That men are, like you say, they're going into IVF clinics that are led by gynaecologists. And in fact, I had a conversation yesterday at a clinic I did a visit to, and who's getting their hands on these guys' testicles? Literally nobody, because the GPs don't feel confident doing it. Gynaecologists don't necessarily want to do it. And so if they don't go and see a urologist, nobody's seeing them. And you're sort of saying, you scan all of your men?
So any man who's got a problem with their semen analysis, we've got a very good protocol. We do a full health assessment on them. So they're all examined. They all have a semen analysis. They all have blood tests, including hormone profile, and they all have ultrasound. Wow. Now that could be slightly, some people may be skeptical about that approach, but every year it saves lives.
Yeah, if you're picking up 10 pre-cancerous testicles.
That's big, isn't it?
That's huge.
Really big. Yeah.
Because what's the implication if you don't pick up on that? I mean, obviously testicular cancer is treatable, but nonetheless, what is the implication if you don't pick up on that?
We know about any cancer. The earlier you pick up a cancer, the better chance of success. So, it's just early diagnosis is the key to everything. So Fatima and I have set up a joint fertility clinic. I think it was probably the first in the NHS. What do you think?
Actually, since we started that, I discovered a couple of others. Very good one in Scotland.
Okay.
But I think it's in our region. It was one of the first ones.
Yeah.
And certainly, I think it took us at least 5 years in the planning and delivery of it. We've been thinking about this for a long time, and seeing all the problems that happen when they're not seen together. We drew up protocols for the primary and secondary care referral pathways. Jas and I developed a very precise when the GP should refer to urology. Then we realized, actually, this woman's been seeing me and the man's seeing Jas, and it's wasting a lot of time. And one of the things that I realized for couples is time. That stress of time passing. Every month the woman has a period. It's depressing for the woman. And so I think we did it for many different reasons. One of them was to save time, shorten that fertility journey. But the other one that Jas has clearly outlined is the impact on the man's health, his emotional well-being, and seeing them holistically together as a couple.
It must make a massive. And this is on the NHS then, is it? So how does that pathway work? Because we talk a lot about the pathway for most couples, and it is that they go to the GP, the guy will have his semen analysis, the woman will have her blood hormones done, and then a few other bits and bobs, and then they get that fertility referral. And that to us is where often the system fails, because it is whatever's going on the male side, they end up in front of a gynaecologist. And sorry, I just got distracted because the food wagon has just gone off.
Turned up.
What's that? What's that?
The most important thing of the day.
But that referral will then be to a gynaecologist, and that's pretty standard across the board. So you guys are doing something quite unique and quite different. How does that pathway differ then? What have you put in place?
Yeah, so before I go into that, if I may just say, so part of the problem we've had is, I think there's not enough urologists who are interested in male fertility.
Absolutely.
Or had the opportunity to be interested in male fertility. And so, we are training more and more doctors, more and more of our trainees coming through and becoming consultants are more interested. So part of it is there's a lack of the right expertise. But as our trainees are coming through, hopefully they'll follow our model. And the model is, Fatima will correct me if I'm wrong, is that it's pretty much what you said. The man will have a semen analysis. The female partner will have lots of investigations in primary care, which are correct. What we initially tried to do was to get all the male partners to have all the right tests in primary care. And it was a bit of hit and miss. But now what happens is both partners are referred to the fertility clinic, and they are triaged by one of our very experienced doctors, and they are worked up. And if they've got an abnormal semen analysis, then they come to our joint clinic.
Right. Okay.
And therefore, they're not lost, and they are treated appropriately.
Okay. So there's another level before they come to you guys. So that kind of
Is that correct?
It's correct. I must acknowledge one of our colleagues, Miss Bano. She's excellent. She's picking up things very well in terms of abnormal. One, WHO definition of male factor, any one semen parameter which is outside the normal range, and putting it all together into one picture, and then referring with the workup done already. And it's taken a while for us to ensure that we got correct protocols and guidelines to be followed. And then they come to us. So it does take away that sort of hit and miss approach. Sometimes the GP used to refer them to urology, and it may be someone, as you said, who's not interested so much in male factor, a general urologist. So it's a bit like a fertility couple going to a general gynecologist. There's lots of nuances of knowledge and experience that I think we bring as a team, which can then be utilized. So the answer really is good pathways, evidence-based pathways based on nice guidelines, adapted to our local needs and services, and making sure you're communicating with your primary care colleagues, with the GPs.
So what's happening in that workup level? What then happens for the man at that point? Is there more happening for him then?
So ideally, they should have 2 semen analyses at least. So a lot of things around the country, they only have 1. So they should have 2 semen analyses at least, which are abnormal. They should have a hormone profile, a full hormone profile. Often the man just has a testosterone. That doesn't necessarily give us all the information. So they should have gonadotrophin, they should have an estradiol, they should have a prolactin. There could be a hormonal reason that they've got a problem with their fertility. And they have an ultrasound in primary care.
Wow, that's amazing.
That's awesome.
This is our dream. Kind of, this is what should be going on everywhere to every patient.
But the way I sell it to GPs is, we're only asking you to do for men what you're doing for women. So women, they have a blood test and they have a scan. It isn't that special. It's just the right thing to do. And our local GPs generally are now on board with this. There's the odd one that is missed out. But actually, when they're referred, most of them have it done.
That's incredible.
That's music to my ears.
Isn't it just? That's like so good.
I always rewind back to like my own experiences, and I just wish that was how it was for Katie.
Your problem would have been solved in a few months, wouldn't it?
Yeah, literally, because we were kind of shoehorned down that road that I had a abnormality in my semen analysis that my morphology was 2%. But it was like, don't worry about that. We'll just do ICSI. Was the conversation as clear as day? And Katie went through lots of investigations, and it was amazing to know that she was under good care. But at the time, I had no idea of all this stuff that I do now. Thanks to Ian, Mike, you guys, all the work that we're all doing together. But just to hear that that's happening for patients now is like so lovely, because my kind of lifelong mission has always been to try and change that.
Yeah.
But knowing that you guys are doing it is really reassuring. And I think from the mental health perspective of a man and a couple, knowing that you two collectively have got that hand for a couple's journey. You mentioned it earlier, it's a couple's thing, rather than it being, let's just look at the woman, it must be her. So Katie, throughout the best part of 6 years of our fertility journey, she constantly felt guilt that she was the problem. So she had mild polycystic ovaries, but she just constantly had this guilt and this cloud over her. And I was like, trying to be strong and trying to support her. It wasn't until that later on, actually, it was all me. And I had DNA frag, I had a varicocele. And coming to your point about kind of checking for general health, I was aware of a lump for a long time, actually quite embarrassed about talking about it, which is why what we're doing at Test Im is to try and end that stigma and break that taboo. But all of those emotional things that we went through could have been avoided had we had this system that you guys have created. And it's so reassuring. I can't
believe that you had 6 years worth of all of that, because
it was tough.
We have very strict timelines as well. So Jas and I and my colleagues within the team, really strict guidelines for GPs. Okay, this is when you refer at 12 months, because the definition is 12 months. But then if there are other risk factors, you refer at 6 months. So, for example, if a woman's, over 35, if they've had a history of pelvic surgery, if they've got history of endometriosis, fibroid, anything, or in the male history, if there's anything. Of course, the male one, we don't discover the history until we've got the semen analysis.
That's the key.
Yeah, but they get referred in. There's a strict pathway because, of course, NHS funding for IVF ICSI is very dependent in different areas, postcode lottery.
Yeah.
So what Jas and I always are fighting against that timeline too, to get the workup done for them, especially for the man and the woman sometimes for genetics. They take about 3 months. We've picked up quite a few rare syndromes through our clinic. And I think it's that thoroughness of the workup, attention to detail about the pathways, and the fact that couples are struggling with stress all the while they're waiting for a clinic appointment, a test. But I think we've worked very hard to make sure that we've addressed those delays that you've talked about. And the fact that the women, often there are lifestyle issues as well. And by which I mean not just physical, emotional as well. And I think one of the things I really learned a lot from Jas, and I think luckily we share the same approach about lifestyle. We are passionate about optimizing the couple. So the man, the woman, and I've seen him, Jas's magic work on men when their sperm improves dramatically once they've lost weight, or they've stopped drinking heavily, or stopped smoking. And I've seen those changes even without anything else. So I think that approach of making sure it's a holistic approach for the man, for the woman, for the couple. And I think that's the beauty of this clinic, isn't it?
But just to come back to one thing you were saying, so what we saw quite a lot early on is that the male partners, quite even when they attend, they don't necessarily open up.
Oh, is that, is that guy?
It's difficult, and I get that. So what we do is we have clinic rooms together. We started by seeing both partners together, just set the scene, go through the results as they are, and then I take the male partner to a separate room,
Right.
see them, talk to them again, examine them.
So hang on, just when you say both together, that's you two as consultants
Yes.
with the couple
Yes.
So you're sitting
in
around
the
the
same
ta-
room. So
Yes.
there's
Absolutely.
four of you
Oh,
in
wow.
effect.
No, there's 5 of us.
There's
There's a specialist nurse.
yes.
Oh my goodness.
Oh,
Yeah.
wow, that's quite cool actually.
She provides that sort of link when they've left and they can't talk to the doctor. She is that one link. They have
Right.
her number.
Yeah.
But yeah, so you're all sat there together. That
So
initial
it's quite a
consult.
busy room. So
Yeah, yeah.
it's quite daunting for the couple to come in. There's already 3 people in there. So we introduce ourselves, and they really appreciate that. And but so then we talk to them together, set the scene, get the history as a couple, go through the investigation they had together already, and then I will take the male partner to a separate room, go through it again, and then you'll pick up things that they haven't necessarily opened up ever.
Yeah.
Examine them in privacy, and then I'll talk to them again. And then when we come back in, we kind of reconvene and kind of establish everything again. So I think they do appreciate it. And the amazing thing is that, I've been a consultant 15 years. Fatima's been a consultant even longer than me, but we learn from each other every day. Every day. And I think that is valuable to ourselves as professionals, but to the patient.
Be hugely valuable to
Yeah.
patients. But have you ever kind of done any or got any feedback from your patients in terms of how they have felt throughout the process, emotionally, how they cope with it? Because one of the big things, and Toby was this patient, like the men feel neglected. They feel like the spare part. They're not part of the conversation. So to have this experience, and some guys might not like it, and they might find it actually a bit uncomfortable. Oh God, I've got to go and have my testicles checked or whatever. But there'll be a lot of men who'll be like, "Oh, great, I'm being treated equally. I'm just part. I'm exactly part of this, as I should be."
It's exactly what you said, a bit of both. So, but most men do not want to be there. They don't want to be there. They don't want to talk about it. But they really appreciate the opportunity to talk about it alone, supporting their partner, but alone. And, I pick up lots of different things which they didn't tell us about, which are helpful. And they really appreciate it. It's a bit of both.
And do you find? Sorry, I was going to ask. Do all couples have that experience? So when they've gone through the primary care, they've done the workup. The next port of call is heading towards IVF or more in-depth fertility stuff. Is that every couple end up having that sit down with you, or is it only when there's a male factor as well that you'd come in, Jas?
Yeah, we have to restrict it because our clinic numbers are high.
I was going to say,
And when you cut down the criteria, yesterday I saw somebody with 2% and then 1% morphology. In a way, in the past, with normal count and motility, maybe we wouldn't have seen them, but we've discovered that we find other things wrong. So actually, the referral pathway is only for male factor. So we're not seeing people with normal semen analysis. So it's meant to be for severe male factor, that clinic. Otherwise, we'd love to see them. I see them both. In our general fertility clinic, we always have to see them both, always. But we only bring them to this clinic if there's a male factor issue.
yeah, that makes sense.
So, I mean, otherwise, it's really designed for that, isn't it?
But I think the key to this is have we changed the natural history? And we've seen so many men and couples where we've done this. So commonly we find varicocele. Commonly we find hormonal dysfunction. Commonly we find an infection in the sperm. And, it is controversial to see, men in that joint clinic who've got normal semen analysis. But we all now know that sometimes normal semen analysis is not a normal semen analysis. There are advanced male testing techniques now which pick up things that a semen analysis alone does not pick up. But that's another step. We haven't got that far on the NHS yet. But maybe in the future that's the
We've
next approach.
talked about it, haven't we? We have said, look, unexplained, is it really unexplained? And there's a lot of research. unexplained infertility, very frustrating diagnosis for couples.
Such a common word.
Scenario. You know, 1/3 of couples will have that, and we've talked a lot about it. We'd really ideally like to examine the male factor in more detail when the normal semen analysis is when they have a normal semen analysis. So. That's another step in our journey.
But the beauty of what we're doing, this is just the beginning. But the beauty is, have we changed natural history? Yes, we have.
Yeah.
Mm.
You know, we've helped couples to conceive without IVF.
which is
yeah.
always the goal if that can be achieved, right?
Yeah.
Because it's not. I think we quite often lose sight that when couples are struggling for having a child, the focus is on just getting pregnant and just having, you know, one child. But actually, this is more about family planning now, isn't it? Because then if you're optimizing the health of both parties, male and female, you're then in the situation then that if they have a baby naturally, there's then a future of more siblings for that.
Well,
family,
not only that, really, because I don't see it as a short term. I see it as a long term thing for the woman.
Yes.
Her life journey, the child, the pregnancy, the delivery. So the beauty of what I do is, because I do obstetrics as well, I see my pregnant women in the clinic, and the things that you can do, such as avoiding gestational diabetes or reducing the risk of problems during pregnancy, you can work on that. And we both have a little bit of a nag to our the couple, say, look, you've got to lose some more weight, but we've got to put it into context, because we don't want to add more pressure for them, but we explain why it's important. And I think that's what we say, you know, look, you're now 36, you've got to get your weight down because you less chance of getting diabetes, etc. And I think Jas's approach is very similar, because I've seen the things that can happen with lifestyle changes, and I'm very much an advocate for that. But also the developments, I think, in fertility practices, both male and female, I think we're trying to keep up with them and make sure that we can utilize the latest sort of developments to help our couples.
And also that leads on to healthy babies too, right? Because throughout that process of a woman carrying a child, obviously there's, you know, huge influence for a healthy baby. And, you know, we know from sperm itself, you know, good healthy sperm, you're basically giving DNA, right? So if you can optimize that, you know, I'm no scientist, I'm here as a patient, but if we can optimize all of that, then we're looking at a healthy future for our children.
Just want to say one thing on that note, which is about varicocele, varicocele and male fertility. We went backwards in this country. There was a nice guidance that suggested that, you know, treating varicocele did not improve fertility. All right, and that's been superseded. You know, studies around the world, there's European guidance, US guidance now that, you know, in the selected population where, you know, there's a problem with sperm, you know, the varicocele is relevant.
It was for me.
But this is what we commonly still come across, is that we are told that, you know, it's not relevant, and it has to be investigated. And if it's relevant, it can be treated.
And are you treating those on the NHS?
Yes,
for fertility reasons.
Yep, absolutely.
Wow, this is amazing.
So your face,
I'm like,
This is the beauty of it, because we're diagnosing them. And we've got now a reason to treat them. As you say, the evidence-based change, when I was training, it was, no, you don't, you just leave these, just do ICSI.
Yeah.
And it's really good that we've got that knowledge base progressing.
So NICE guidance was based on skewed data. It was a big meta-analysis, but they looked at the wrong things. They looked at subgroup analysis, which was wrong. But coming back to varicocele, there's many ways of treating a varicocele, right? So the simplest way is something called embolization, which is done by a radiologist. It's done when you're awake. You walk in, you walk out. It's got a good success rate. For patients who've got larger varicoceles or more complicated varicoceles, I do microsurgery on the NHS. And, you know, it can be an amazing results, but it's got to be a bespoke treatment for the patient.
Yeah.
So it's a team approach, a joint approach.
So I'm just interested how you've managed to get this all in through the NHS. Obviously, you know, you said it took you many years to kind of build this service, because this is entirely unique. I think I've never heard of this anywhere else, because we tell men, like, you know, you'll struggle to get your varicocele treated on the NHS for fertility alone. So how have you managed to set up this service and get the resources and the funding for it?
No, I think it's always been there. It's the right knowledge. So part of the part of the problem is what the guidance is. So the guidance does say that you shouldn't really treat varicocele for fertility. There's but really, if you drill down on the evidence is there. So part of it is education, but part of it is having the expertise to do it. You know, like for example, a lot of my colleagues won't do microsurgery because they're not trained to do it. But embolization is still a good option, but not for everyone. Right? But it's certainly, it's about opening minds. It's always been there, but you've just got to be able to, demonstrate the evidence.
Right. Yeah.
It's fascinating.
And obviously the GPs in your area, then they've come on board with all of this. So they kind of.
Yeah, I mean, the GPs we cover now, we have an integrated care board, which spreads across a wide area, and they're different PCNs as part of the integrated care services. But we just have to communicate well with them. And that reminds me, I think we need to do a joint session for our colleagues again. We've done it regularly. I think the other thing that we have is a very good team of clinicians, consultants, radiologists that we work together with. So, for example, embolization, we've got very skilled colleagues who can do that on the NHS, and they do really a good job, and they audit their work, and we see improvements in semen analysis following embolization. Yeah. And then you've got, I'll let you talk about your network we've recently collaborated with other colleagues. We're just trying to utilize all the NHS resources. I mean, bearing in mind that male factor on its own affects about 30% of couples. And then there's a lot of overlap with female and male factors, about 40% of them. So really it comes down to a team approach. It can't be anything other than a team approach.
100%, yeah.
And so really what we're trying to rectify is that imbalance which has been there for a long time, trying to just focus on the woman. I mean, I, of course, focus on the woman, but then we got the couple and we just work together. And what you've said is really, really interesting about optimization, I think, Jas. Optimization for the woman, for the man, for the couple, for the baby, for the family.
Absolutely.
And if I may just say, so it totally is a team approach, not just Fatima and I, our nurse specialist, Dr. Banu, all the other gynecologists like Dr. Doncheva, etc. And there's other people we haven't mentioned, and our radiologists. But we also, our joint clinic isn't just for Heatherwood and Wexham Parkside, it's for the Pan Frimley.
Yes.
So we get all our the joint referrals from the Frimley side as well. And now more and more we are getting referrals from other trusts.
Oh, really? So other trusts can refer in?
They can, yeah, absolutely. And especially for my service, for the male fertility side. But as Fatima mentioned, so I'm now part of this South Central Andrology Network, which is High Wycombe, Frimley, Reading and Southampton. So the urologists from that area, we talk about a lot of these issues. We collaborate, guidelines, support each other, difficult cases. So I think it's a team approach. It's a wider team approach as well.
It's got to be, hasn't it? I mean, making a baby takes two, takes a sperm and an egg. And it's just absolutely fantastic to hear that you guys are doing it so thoroughly. What's it mean for your success rates or your kind of patient outcomes?
I think we've got to view it again in a way of the emotional impact. Is the outcomes emotionally, I think, for the couples are really good. In terms of pregnancy rates, but we're not an IVF unit. So in the NHS, when we see a couple, they need IVF with ICSI, often with severe male factor. We have criteria which we refer them on to an IVF unit, which provides that service. So those success rates are measured by those units. Of course, some patients don't meet the NHS criteria, but regardless of that, there's a big thing that we don't see women over 35. So of course we do, because we want to help all couples. They're paying through their taxes for NHS. We want to see them. We have a cutoff of age 42 for females. And those couples, we still do all that workup, which is, if you did it in the private sector, would be very expensive.
Sure.
So we help those couples. And then the thing with going on to the success rate, I think the biggest thing for us is the natural conception success rate, and then the optimization of the sperm. And then we have an ovulation induction program. So women with polycystic ovary syndrome, if the male factor did improve, it's not a severe one. Yes, of course, we're going to optimize their weight loss, get their cycles regular. And in time, those women could conceive naturally. We do have a time limit because, of course, with fertility, it's really important to be aware of that. And similarly, there are women who've got fibroids in the cavity, so I can do their surgery, remove the fibroid, and then hopefully some of the sperm has got better in the meantime while they've been on the waiting list. They can hopefully get pregnant. And the endometriosis patients, if they've got problems with endometriosis or tubal factors, we'd address all of those. So for a couple's journey, what the best thing about our service is I think things are happening to the man and the woman concurrently. So when we see them, things are moving for both of them at the same time, and hopefully we can get to the stage where if they're eligible for funding on the NHS, we can refer them on.
Yeah,
I love this. Like this honestly is music to my ears. We see so many men on our support group that don't have this. And they struggle.
And they go to private clinics. They're paying through the nose
Yeah.
for treatment and not getting an ultrasound, not getting an infection screen, not getting a physical examination even.
No. But I mean, that just goes down to saying that private treatment isn't always better. It's who you see.
Yeah.
It's a team approach. But just to answer your question about outcomes, and Fatima said this already, but just to reiterate it, there is no doubt that we've increased the natural conception rate. Absolutely no doubt in that. One of our trainees is going to audit that shortly because this clinic's only been kind of under 2 years now in running. It took us 5 years to set it up. But
I didn't realise it was that new. And I know you sort of said 5 years to build up, but it's only been running a couple of years.
Yeah.
About 2 years now. And so one of our trainees is going to audit, and we'll hopefully next time we come on, we'll tell you the figures. But there is absolutely no doubt that natural conception rate has gone up. What I also think is that the IVF ICSI rate has also gone up as well because we've optimized them. We don't have that data because Fatima explained why, they go to different clinics. It's hard to pick up that data.
Sure.
But I have anecdotally, there is no doubt in my mind that we've improved the IVF outcomes as well.
That's just incredible. I mean, everything we stand for is optimise both, and then and this is what we say, because you will help natural conceptions, you help couples have a child the way they want to have a child. And no couple want to have IVF. They want to have a baby, but they don't want to have IVF. They'd much rather conceive naturally.
And coming back to the kind of things that men talk about with me alone in the room, but in the joint clinic, is things like erection problems.
Yeah,
it's a huge burden. We know that men temporarily have erection problems going through fertility, which is unsuccessful. It's a big problem, and they don't talk about it. And if you don't talk about it, it gets worse. It gets worse and worse.
That's difficult, isn't it? Because there is that kind of like, when you're trying for a baby, there's that thing that takes over where the ovulation sticks come out. We've got to have sex now.
Correct.
The performance anxiety for a guy then is like, I'm just want to go and have a bacon sandwich and chill out for a bit.
I want to go on my bike.
There's and it is just real, right? They're real stories, aren't they? And we hear from guys in our support group, and my own experiences. It's a real taboo, and it's so nice that you're giving that environment for a guy to actually be in an open discussion, because quite often it's guys just need to know they're kind of, I've got you kind of. Sort of feeling, isn't it? That's what they need. We've got you, and you're offering that to a guy, and it's such a nice thing to hear, because I only ever speak from my experience, is that for the majority of that 6 years, until the point really I met you, Ian, because you were kind of like the kind of fundamental part of how I changed my whole life. But I just felt like some lost sheep in an environment. I had no idea of the language. I felt scared. I was worried, would we ever be parents? And I never spoke out to anyone, to the point where I got really depressed. I needed counselling in the end. I needed to go and see someone professional to sort me out, because I was in a really bad place. So what you're doing, the intervention of all of that stuff is really great. And conversations like this, I hope from our viewers that it is breaking this taboo and stigma, that we can be really open to talk about these things, because it's so important. And
I mean, I just thought of something when you were saying about the erection issues. Actually, in a way, the male factor should actually, the definition should spread across that side of things. So there is a focus just on the semen analysis, okay?
Yeah.
And I think, in our fertility clinics, we take a sexual history. How often are you having intercourse? Dr. Bano is very good at picking that up. And she will refer those people to Jas, even though the semen analysis is normal, which I think is really important. Similarly, I trained in psychosexual medicine as part of my training for fertility. And for women, it's also can be an issue.
Yeah.
Painful intercourse, maybe due to endometriosis or vaginismus or other things which are really not there. And I think that's the beauty of practicing in this field. You will come across lots of other things. And you mentioned the emotional factors. We have a counselling service within the NHS, which is quite stretched, but I think counselling is really, really important.
Yeah.
Not just for IVF, it's that journey leading up, because when couples get to IVF, I find their stress levels, we don't want them to be high. We want them to have now understood what it means and to be in a place where they're ready to start. So I think focusing on the mind, body relationship's really important.
I think that's such a valid point. Like by the time they get to you, and I talk about this when I go and do clinic visits and talk about, the male fertility and the typical fertility journey. By the time they get to any specialist, whether it's a urologist or a gynaecologist, whoever it is, there's been 2 years of trying. There's been the ovulation prediction kits. There's maybe been a miscarriage. There's been performance issues. There's been erectile dysfunction issues. There's been stress at work, all the stress at home. Like they're coming to you with a massive amount of baggage, aren't they? And some of these couples are not getting this level of support. They're just getting pushed through a system, and it's no surprise that kind of post-traumatic stress disorder is quite high, isn't it? And I can't remember what it's called. But anyway, in women, postnatal depression, is very high in women that have been through fertility treatment as well. It's because all of this beforehand is brought to your doors, isn't it?
No one's really addressed it. And I think one of the things I've seen with the couples who sit there, although they're a little bit daunted when they meet us, they're actually quite relieved that we're also addressing those emotional issues. And I think the other beauty of having the couples together is the woman feels that support from the male partner.
Yeah, she's not on her own. It's not all about her.
She's not on her own, and they I think that it's just the dynamics of their difficulty with conceiving, because let's not forget that's the only reason that they're there. That dynamics changes. They begin to trust health professionals again. They don't feel they're being dismissed. It's a very important thing for couples to feel we're taking them seriously, and I think that's what our clinic does. And our fertility specialist nurse, Charmaine, she's excellent. She's really supportive. She connects with patients. So we've got a really good team.
Yeah, we really do appreciate when they come into the room. This is a long journey, and they're still on a long journey. But this, by the time they've got to us, they've been through a lot already. We do really appreciate that, and we talk about this before they even come in the room to say, look, what have they been through before? What's been done?
Yes.
So we appreciate the timeline. But just to mention a little bit more about the men's side, because I think my experiences, and it may be wrong, is that women tend to open up a bit more. The men do not. And when they are given a chance, they do.
Yeah. I was going to ask you, once you have that consult with them, do they then say, oh, actually, this is going on or that's going on? Yeah.
Lots of stuff comes out. Another important bit is Movember. It's just Men's Health Awareness Month, right? And bring that in. I mean, every year I try and grow a beard or a moustache. It looks silly. I've kept it growing this year.
The beard's looking good. That's a sharp-looking beard.
Well, anyway, that's another story. But I've kept it going this year. But it's another topic for conversation when patients come in and they say, oh, you didn't have a beard last time. And I say, yeah, I did it for November. They say, oh, and then it brings up another conversation. It's just a way of getting men to speak, to open up, to say anything. And then the conversation is endless.
Yeah, I must admit, I found when my acupuncture practice was predominantly female focused, fertility based. But when I was like, hang on, I need to do something for the men. There needs to be something for the men. What I did was like my female patients that were going through fertility treatment, I said, look, can I chat to your husband? I'd like to find out what his experience is. And I'd do a full clinic evening. I'd finish at 8 o'clock. I'd then go and sit in the car park or I'd be in my clinic room and I'd phone this fella and be like, right, look, I'm just doing a bit of market research really. Just want to find out what's going on for you. I spoke to maybe 4 or 5 guys, and I heard the same thing time and time again. No support, no information, no testing. We were about the finances, everything that is core to our mission now. But you know what? When I gave them that time, I was on that phone for an hour at least every single time. Because once somebody's actually given them a little bit of attention, asked them how they're feeling, what's going on for them, they're like, oh, great, somebody actually cares, somebody's interested. It makes such a difference.
But it's just getting that something in common to get them started. And that's what we found, that, actually taking them to a separate room is valuable.
Yeah, that's
that.
a really good setup we have there.
Yeah. And actually, sorry to butt in, I think actually just talking to you guys now is that you talk on a language that is really understanding of a patient. And I think as a patient, when you go into this space, it's quite overwhelming. There's a whole new language to learn, TTC and all these kind of algorithms, all these words and stuff. But actually, you're talking on a language that's you're a human.
Yeah,
you've got feelings, and I get you. And that's really all you need to offer. And it's amazing, like you say, how that just opens a conversation to allow that person that room to speak. And it's just so powerful. It really is.
I was just, to quote a colleague actually, I heard something which is very nice, I think. When you're a doctor, you're not just caring for patients, you're caring about patients. And I think that's really quite powerful.
Yeah.
Because I think the thing we have lost in medicine, as technologies advance, we've got long NHS waiting lists, everyone's very frustrated. There isn't any substitute for just human understanding of the predicament of a couple wanting to have a baby, which is a very natural human desire. So I think that is what our philosophy really is about the holistic care of that couple, isn't it?
Absolutely. And I think, not to be detrimental about IVF clinics, I think it's actually very difficult to do that in an IVF clinic.
I'd agree. Yeah.
Right? Because you're there for a function. It's function. It's a baby.
Yeah.
So it's very difficult to be holistic at that point. To be, very
To give that time.
true.
It's difficult because there's a timeline.
There's a timeline,
And actually, all of this should have been done way in advance, like what we're doing.
Yes, it takes sometimes, and I'm sorry to go on about body mass index, but I think it's something we need to open up about to women. And I'd actually like to educate a bit more about the impact of BMI and female age. These are the two biggest things, I think, as obstacles for me in getting women pregnancy rates up, etc. But to talk about those issues, which take time to address, don't they? Because they're not just physical. They're not just about...
Yeah, if
that.
somebody's
It's emotional.
overweight, it's not...
There's a lot of...
that
In
can
fact,
be very complex.
I would say I've learned a lot from you in that sense, that I think it's exactly the same for the man. It's exactly the same for the man.
Right.
The BMI and age, right? So
But they don't get told that.
no, they don't. And
Nobody's questioning that.
But we do.
We
in our clinic.
measure them both.
Yeah, we
Yeah,
measure
yeah.
them
Do
both.
you?
Yes.
But
we
at
do.
GP level, and I said this yesterday at this clinic talk, is like, a woman will be, I use the word judged, but it's not necessarily the right word, but should be judged by her BMI.
Oh, yeah.
But because it's a defining criteria for IVF, which is understandable. There's medical reasons for that, and,
Yes.
and like I say, there's risk factors. But
Yes.
for the guy, his BMI could be 45, and the GP might say, "Oh, you need to lose a little bit of weight," but that's it.
Yeah.
But actually, a BMI of 45 for a man, and he's 39, that's going to be a significant factor.
But I think
It's a big health risk.
Yeah, it's a health risk.
Yeah. But the thing I commonly see when we do address it with men, we say, look, your BMI is a bit high, and the typical approach I get from a man is, BMI is not really accurate.
Oh yeah, because they've heard muscle masses.
And they go
excuse
down
it.
that road, and I said that's okay. I said I appreciate that.
Yeah,
I appreciate it's
yeah.
not always relevant, but it's a good marker. It's a marker,
It's a marker.
We can all do better. Look, I can do better. Right? So it's a human approach, but I've learned a lot. I think BMI in a man, there is no doubt that a BMI in a man, it affects their hormones.
Yes.
Right. So we know about testosterone, we know about estrogen and the imbalance. We're learning more and more about that. So that's something we can address quite quickly. Age, we've always thought that men who are fertile forever. We hear about the Robert De Niro's of this world, right? However, they're just a subgroup. We now know that actually, even if your semen parameters are normal as you get older as a man, the DNA quality goes down as you get older, right? So this is advanced sperm testing.
Yeah.
but it's age and BMI are relevant in a man.
Yeah.
Just as much as anyone. Yeah, absolutely. Do you think you will, or are you trying to, and do you think you will get to a place of bringing some of these advanced tests in on the NHS within your clinic, so such as oxidative stress or DNA fragmentation? Is that too far away?
What, do you want to answer? Shall I answer?
No, you go ahead.
I certainly hope we do. I don't think we will in the short term. And the reason is, again, the guidelines. You know, you mentioned how did we get, for example, like varicose treatment on the NHS? Because we can justify it. Until we get better evidence and national guidelines to say that it's necessary, it's going to be really difficult on the NHS, right? But I think, you know, there is no, you know, what we see more and more, though, is patients bring in the advanced testing into our clinic.
Yeah.
The results with them, which is absolutely fine. You know, I have no problem with that. As long as it's done in a reputable place, we can interpret it.
Yes.
So we could, you know, there could be a halfway house to say, you know, get these things done, bring them in if they're relevant for you. But I think it would be difficult in the short term to get on the NHS.
I think the funding thing, I think you've touched on a good point there, this halfway house concept. There is this thing, isn't there, about NHS versus private. Private's better, NHS not that good. And there may be patients' experience and different things throughout the country. But what our approach is, get the best you can from the NHS. Do everything you can, because don't forget, women who, in our region, if you're over 35 as a woman, you don't get free NHS-funded IVF. That's a shame, but that does not mean we cannot help you in our secondary care setup for fertility. And so really it's to do with us trying to identify and guide the couple. Look, you really need to have IVF with ICSI. Unfortunately, you're outside the criteria. And also, actually, if you did want to get this other test done, this would be helpful. But right now, as Jas said, once the evidence is solid, we may be able to get it on the NHS. But some people would get it anyway themselves because they've read about these tests and they think, well, we're not giving it to them because for whatever reason. And you can do a bit of mix and match. I don't think there's any harm in that.
Yeah,
I think
what we're also seeing, sorry to interrupt, is you know, patients coming in are much more learned.
Yes.
They've done their research.
Yes.
Yeah, they've done their reading, and they have knowledge. Not always the right knowledge, but they have knowledge,
Yes.
and we're here to kind of signpost them and advise them appropriately. But you know, a lot of them will have already had these tests done.
Yeah.
Because they've been listening to your
the
podcast.
Yeah.
Which is great, right? But you know, and we advise them appropriately. You know, it's a team approach.
There are actually, we should talk about NHS funding for couples, and I think it's a shame that it isn't more widespread. But in terms of the approach that, you know, majority of health areas have, is that you shouldn't refer the woman if she's above 35, but that isn't correct. So I want to just rectify that issue for our region at least, because there's a misconception that IVF is the only way to get pregnant. It's the only fertility treatment.
Oh, it's held up as a solution, isn't it?
Yeah.
And of course, it's helped loads of couples, and many couples will end up with that. But there are lots of pregnancies along the way, aren't there, before you get there? So this is our approach. Look, if you're in the NHS, we'll do our best. And the thing I just want to come back to about the BMI criteria for women. Yes, there's for NHS funded everywhere across the country is BMI less than 29.9. But for me, it's not just about the NHS access. For me, it's about the woman's health.
Yeah.
We know that, you know, high BMI is associated with lots of things, whether you're pregnant or not. So I think it's optimizing health. So we're never judgmental, but we want our patients to trust us with the information that we're going to be giving them to help them achieve the best health, the best pregnancy.
Yeah, but what I like what you said there is it's not about ticking a box to get funding for IVF,
Absolutely not.
BMI being one of those. You're actually talking about it from the fact that the care of that patient is, I want that patient to be below this BMI because of X, Y, and Z, not just to tick a box for funding. And that's so nice and refreshing to hear, is that the care here.
I thought everyone thought like that.
Well, I would not sort of, you know, I stress the point that everyone that works in this space that we all care for sure.
Yeah.
But the perception from the patient can feel like things are a bit of a tick box exercise. But you just having this language like this it's just so refreshing. Honestly, this has been such a lovely episode today. I'm so grateful for your time, both of you, talking about all this amazing stuff. It's just from me on behalf of all the patients that we support. Genuinely, this means a lot to me today, and it's so refreshing to hear such a great conversation around what you guys are doing.
And I think, the NHS gets a hell of a battering, doesn't it? In terms of, we don't get this, we don't get that.
Yeah.
And I think that's what's really nice to hear today is that you guys are in the NHS. You've clearly put a lot of love and passion into this, and you've built an amazing service that is completely patient-centric. And like Toby said, you're talking about, it's been a very human conversation, this. It's been about the people. And to know that people can get this on the NHS, they can see fantastic clinicians that really care and want to make a difference. It's just absolutely fantastic.
Well, actually, I've been looking forward to making this episode ever since I first met you. I thought, gosh, he's a sort of person that, we want more people like you to know about this, isn't it, Jas?
No, I think, look, we've talked about this for quite a long time coming on board, and it's been difficult with all our timetables. But I think the key is, look, it's really, we want to act as a marker for other clinicians to say, look, this is possible. It's not easy. It wasn't easy. It took us 5 years.
Yeah, that's incredible.
Yeah, it wasn't easy. But once you start doing it, you see the benefit of it. One of the challenges we have in the NHS is the NHS is, so much about acute care, cancer care, diabetes, etc. But and fertility, I don't think gets the coverage in the NHS that it deserves. How important it is. I mean, if we don't, we know there's a fertility problem in the world, really, and if we don't help couples to succeed, who's gonna run the country?
Yeah. Who's going to pay the taxes in the future?
It's actually quite an important point, isn't it?
Talking like a politician there.
But it's true, isn't it? But but in the NHS, generally, fertility doesn't have the coverage it deserves.
Absolutely.
But there's so many other challenges. But it's really a marker. I'd like to act as a marker to say that other like-minded clinicians can do the same.
I think so.
I was going to actually ask you that. I'm glad you've mentioned this. It's like, do you think you could now take this model and take it to other care boards or commissioning groups or whatever they're called these days, and say, look, actually, here's what we've done. And actually, once you've got data and you can say, and we've picked up X many pre-testicular cancer issues, is it a model that you can now just say, take it somewhere else and somebody else can replicate it, do you think?
I don't see why not. But I think it's got to have buy-in. You've got to have the right clinicians to want to do it as well. And we're very happy to talk to other colleagues who want support and help to do this. But you've got to have the buy-in. That's the trouble. It took us a long time to convince everyone, but now our trust is so supportive of it.
It is, although, sorry to say this, but because of the NHS pressures on gynecology appointments, one of the first services they start talking about they'll cut is fertility. And it's wrong, because fertility is a specialist service. It's taken me, 20, 25 years to get to this level of experience and knowledge and learning from colleagues. So I think whilst the basic stuff, I think the primary care colleagues are great at doing that. They're really good. And I'm very supportive of my GP colleagues. There is a level of knowledge that's needed for specialist fertility for men and women and combined. But sadly, there is a move to get to reduce that because of the cancer waiting times, general gynecology. So I'm always fighting very hard for my patients to make sure they have access, because actually not everybody can afford private care, and health inequities are very, very important to address. We mustn't forget there are people who even have trouble getting to our clinic. It's a little bit way out in Ascot, and they're traveling from Slough, and it's hard for couples. And I think we need to support everybody equally across the different areas.
It's a big problem, isn't it? Like the funding and,
Yeah.
and where do you put, if you think about it, if somebody's got to sit there with a pot of money and say, right, where do I put this money? You can see that, well, actually cancer care is really important, care for the elderly, and whatever it is, like, pediatrics, it's really hard to,
But
how do you divvy up that
that's
pot?
why I kind of keep bringing back to the point where, when if someone says to me, well, look, fertility is not that important, I say, well, look, it's to do with the general health. It's maybe the only time a man gets a health screen.
Yes.
It may be the only time. It may be the only time he ever comes.
Yeah.
And like I said, we find testicular cancers, we find hormonal imbalances, we find genetic anomalies like Klinefelters, which have a huge bearing on someone's life. But there are special clinics available for these patients, and we find these things. Linked to BMI closely, I think, is diabetes, diabetes and pre-diabetes. Every week that we do a clinic, I find a man who's pre-diabetic who didn't know. Right?
Yeah.
And so, actually, if we can stop them becoming diabetic, we've saved a lot of money for the NHS. We've saved a lot of comorbidities and problems for the patient as an individual. But there's a health saving, and so whenever someone says to me that fertility clinics are not that important, I just try and remind them that it is the one time a man may get a health screen.
That's
Absolutely.
true. The men need to be looked after.
Absolutely.
Yeah.
I think on that bombshell, what a closure to this podcast. Thank you both so much from the bottom of my heart. Honestly, it really means a lot that you guys are doing this. And I know on behalf of all the patients we support, this is such a refreshing conversation. And also, thanks for taking the time out to come and visit our podcast studio and record today.
But just to wrap up, where do people find you? How do they reach out to you and find you both?
Fatima, do you want to go first?
Fatima.Husain. No, hang on, let's start this. Well, I work in the NHS at Frimley Health. That's my NHS space. I also do private practice at Windsor Gynaecology. People can probably Google me. I don't know what you're going to say.
So the same. So NHS, we're on the NHS website at Frimley Health.
Yeah.
Privately available at urologynow.co.uk, all over social media, Instagram, X, Facebook. Not too much, just a little bit.
Yeah.
Not too much.
Not on TikTok.
No, not TikTok yet.
Have you got Urology Now on Instagram?
Yeah. But I don't put too much on there. Just very very important messages that I think I'm not one of these people who bombard 10 messages a day, maybe one a week or one every other week. So it's just good general men's health messages.
Nice. We'll put that in the show notes as well below. So by all means, click.
You can put my windsorgynaecology.co.uk is my website.
Yeah.
I don't have Instagram or anything. Maybe this is a beginning of just trying.
It's the start of your social media journey now, isn't
it?
I
wouldn't rush there if I was you. But yeah, both of you, thank you so much for your time today. This has been such an awesome episode, so uplifting and so positive. So thank you for all your work.
Thank you for having us, and we would love to come back and maybe give you the data.
I'd love that.
I think we'd love to come back. And we just see this as an opportunity for couples, men, women, just to have that journey softened a little bit.
Yeah. Absolutely.
Well, we'll get the date in the diary now for about 2 years' time, probably.
Awesome. Yeah. Thank you so much, everyone.
Thank you.
Thank
Cheers.
you.
Bye-bye.
Thank you.